I would like to thank the GOG and the Society of Canadian Colposcopists for inviting me tonight to talk about management of vulvar intraepithelial neoplasia. I have no financial relationships to disclose. However, I will be discussing off-label use during my presentation. I will let you know at the time I'm doing so. Other disclosure is that English is not my mother tongue, so there might be some mistakes, but please bear with me. As stated by Dr. Mirand, the learning objectives tonight will be to review the different types of VIN, discuss the available management option, as well as establish an appropriate follow-up for patients with this pathology. The plan of the presentation for tonight, so I will start just by reviewing terminology, and then I just decided to separate through the three different types. So usual VIN, differentiated VIN, which I will refer to as DVIN, and other precancerous lesions. I will not talk about Paget's disease, which is a type of precancerous lesion, but in a whole other family. So if we start with terminology, I didn't go all the way back, but started with the WHO in 2003, which classified VIN as 1, 2, 3. In 2004, the International Society for the Study of Vulvovaginal Disease changed a bit the terminology, and VIN1 became flat condyloma or HPV effect, and then VIN 2 and 3 was grouped as VIN usual type, and we saw the introduction of VIN of differentiated type. The last nomenclature in 2012 was only talking about low-grade or high-grade lesions, and the WHO in 2014 kept the same terminology with low-grade and high-grade, and finally in 2015 the ISSVD adopted LSIL, HSIL, and DVIN. So if we start with usual VIN, it is the most common type of VIN, representing more than 80% of these lesions. It happens mostly in younger patients, so in the 3rd to 5th decade of life. It is an HPV-dependent lesion, so the most common HPV types are 16, 18, 31, 33, 45, and 52, with HPV 16 being the most common. It's detected in about 70% of VIN2 plus lesions. Risk factors are similar as to risk factors for HPV infection, so smoking, immunocompromise, and the number of sexual partners. If we look at immunocompromise, I just thought it would be interesting to talk about it a little bit more. There are different categories of patients. So we have patients with HIV or AIDS. There are also patients who are on medication for chronic diseases, such as rheumatoid arthritis or Crohn's disease. And so medications that are used in these pathology can alter the immune system. We do know that azathioprine increases the risk of genital dysplasia in a dose-dependent manner. And we also know that TNF-alpha blockers will lead to activated T lymphocytes and macrophages apoptosis. Interestingly, there are some newer drugs for some of the chronic diseases that are more targeted therapies, such as gut-selective antibodies that can be used for Crohn's disease, and they might not increase the risk of genital dysplasia. Another group of immunocompromised patients are patients who had solid organ transplant, and it's estimated that about 3.5% will develop some kind of lower genital tract disease lesion once they are under immunosuppressants, and the median interval for development of such lesion is about 3.9 years. And finally, there are some innate immune disorders that I will not detail here. If this is a quick slide to just go back over how HPV works. So as you know, so here we have HPV. HPV will be integrated in the host cell genome, and this will alter expression of multiple proto-oncogenes and tumor suppressor genes, and will lead to overexpression of E6 and E7. E6 will cause p53 inactivation. E7 will lead to retinoblastoma degradation. And as you know, both of these genes are tumor suppressor genes. And so this will cause disordered cell metabolism and then lead to malignant proliferation. If we go over pathology, so the microscopic features for usual VIN will require a near full thickness or full thickness epithelial involvement, as well as nuclear enlargement, which you can see on the diagram here. There will also be minimal maturation, from the basal layer to the superficie, and brisk mitotic activity as well. Interestingly, the International Society for the Study of Vulvovaginal Diseases just published their guidelines in early November, I think, for histopathologic diagnosis of VIN. And so it's interesting because they really describe well the role of P16 and P53 in pathology diagnosis. So as you know, P16 is a surrogate marker for HPV infection. And in patients with usual VIN will have a positive P16 staining, whereas P53 will usually be negative, or we can have some staining for P53, but just around the basal layer. If we go with the clinical presentation of usual VIN, so patients can be asymptomatic, they can have pruritus, they can have burning sensation, they can have pain. It's hard. Some patients, will have extensive disease and have no symptoms. Some patients will have a tiny lesion but have a lot of pruritus. So they just need to be examined properly. When you examine patients, so you can have different types of lesions. They can be white, they can be pigmented, they can be erythematous, they can be flat, they can be raised, they can be ulcerated, and they can be unifocal or multifocal. I know traditionally we have said usual VIN or HPV-related disease is multifocal, but it can be unifocal. And the other thing that you need to remember is that you can have HPV-related VIN, so usual VIN, on top of extensive lichen sclerosis. The question is always, it's a precancerous lesion, so what is the risk of cancer? So for patients who have surgery for VIN, the risk of occult invasive cancer at the time of surgery is about 3%. Hopefully, one of the good aspects, though, is that 2/3 of these invasive cancers are very superficial at the time of the surgery. So they don't require extensive surgery or nodal assessment. The risk of progression to cancer, so a patient who does not have cancer at the initial diagnosis, is less than 10%. So it's about 3% in treated patients. And in patients who are left untreated, it goes from 9 to 16%. And finally, the median time to progression for patients with usual VIN is about 41 months, so a little bit less than 4 years. So how do we diagnose these patients? As I was saying earlier, visual inspection is really the cornerstone of diagnosis. You can also apply acetic acid at concentrations between 3 to 5%, like we have in colposcopy. However, you do need to bear in mind that because of keratinization of the skin of the vulva, it requires longer application for it to work. So you will need to apply soap gauzes on the vulva for several minutes, which can actually cause a lot of burning for patients. Then there is a question of biopsy. So in my book, when you have a vulvar lesion, you biopsy it. When you look at guidelines, they don't necessarily state that everyone should have a biopsy. Often what will come out is that postmenopausal women should have a biopsy, even if it looks just like a condyloma. Patients who do not respond to treatment, usually patients who are immunosuppressed. But I think it's always safer to get a first biopsy and then follow. Also, it's very important to assess the entire lower genital tract. Since it's a HPV-caused lesion of the vulva, they're at risk of developing either vaginal or cervical or perianal lesions, so you do need to assess it thoroughly. Management will vary depending on patients, depending on their lesions, and depending on their past history. So it will depend whether it's a small lesion, if it's very extensive, where it's located. Is it near the urethra? Is it on the clitoris? Is it, on lateral, on a labia majora? Is it near the anus? Is it unifocal? Is it multifocal? Do you have some all over the vulva? And then the patient. Is she young? Is she sexually active? Is she older? Does she have comorbidities? Is she symptomatic? And is she reliable for post-treatment follow-up? And lastly, has she ever had any treatments? If the patient had multiple vulvectomies, then you might not have as much margin to do another resection. If she had laser surgery but has developed a scar which is impacting on her quality of life, then it might not be a good option. If she already had 4 treatments with imecuma, then you'll have to reassess. But first of all, if there's cancer suspected, don't do an excisional biopsy. Refer to a specialized center before doing anything. You can do a punch biopsy to get a diagnosis, but sometimes patients have a resection of the lesion for a diagnosis in the OR, and then there's cancer, and then it's a bit harder for us to manage the cancer with the sentinel nodes and all. So if we go through the options of management, observation is clearly not a standard of practice, but it does appear in the literature. Spontaneous regression of usual VIN is less than 1.5%. The cases that have been described are women who are under 35 years old or who had their lesion diagnosed during pregnancy. So these patients you could consider observation, but this is really not standard. What we have seen mostly, over the years is that surgical management appears to be the first choice for a lot of gynecologists. And you have different options. So you can either do local excision. So you don't need to go very deep. It's not a radical vulvectomy, but you will aim to have some clear margins. Guidelines say between 5 millimeter and 1 centimeter, just because the risk of recurrence is lower if your margins are negative, but it does not go to 0, your risk of recurrence. In some patients who have extensive disease with multifocal lesions, sometimes you can do an extensive skinning vulvectomy, so very superficial, but it's quite an extensive surgery. Electrosurgery, we don't see that a lot in the literature, but it's an option. It can be done in colposcopy. If you have a machine to do leaps, then instead of putting the loop, you just put the electrocautery ball, you do a local anesthetic, and you can actually burn a bit, and you go as deep as you would go with the laser. So it's a good option for very, very small lesions, and you're able to manage the whole lesion at, in one setting, and you don't have to have them come back for the OR. And there's the laser ablation. So this can be done either in clinic, if you have one in clinic, or in the OR, depending on how much disease there is to treat, if you can do the anesthesia, like is local anesthesia enough in clinic or not. You will need to burn through the entire thickness of the epithelium up to 2 millimeters in the dermis if it's a non-hair-bearing region, such as the labia minora or near the clitoris, although it will hurt. And in hair-bearing areas, you need to be able to ablate the hair follicles because you can have HSIL there, and then extending the subcutaneous fat for 3 millimeters maximum. The risk of recurrence appears to be a little bit higher with laser ablation than with excision. And then again, you need to aim to treat for clear margins all around the lesion. The downside of surgical management is that there can be an impact on body image and sexual function. So sometimes it's not the best option for younger patients who are sexually active. When we look at medical management, we have different options. The most common is topical imiquimod. There's also cidofovir. There's a photodynamic therapy, and 5-FU has been reported, although it's most commonly used for vaginal intraepithelial lesions. So I will not be discussing it tonight. If we look at imiquimod, so this is completely off-label. It's an agonist of TLR7. So you can see imiquimod here, which binds to the TLR7 and 8 receptor of dendritic cells, which will activate antigen-presenting cells, which in turn will activate native T cells and natural killer cells, and then stimulate acquired and innate immunity and give the anti-tumoral effects. This is a topical treatment, so it's in the form of a cream. You have different concentrations, 2.5%, 3.75, and 5%. 2.5 and 3.75 are most commonly used to treat genital warts, although it can be used for vulvar dysplasia. In the past year, we've been back order at some point on the 5%, so we had to go back with the lower concentrations. The 5% cream needs to be used 3 times per week at bedtime. It needs to be kept on skin for 6 to 10 hours, and afterwards the patient needs to wash the skin. The treatment is to be continued until resolution of lesions, so maximum 16 weeks. You do need to reassess patients during the course of the treatment to make sure they're tolerating the treatment and to see whether it's working or not. Side effects of this treatment most commonly will involve local skin reactions. It can be erythema, it can be erosion, it can be excoriation, edema, and sometimes patients have very, very, very severe reaction. So if they do have one, they need to remove the the cream. They just need to apply mild soap and water on their skin. And treatment can usually be resumed after the skin reaction has subsided. However, when I usually have patients start it again, I start it, not as often to see how they're tolerating. Also, sometimes when they have a very, like a full-fledged reaction, sometimes it just stimulates their immune system, and lesions just, disappear by the time their reaction has resolved. Other side effects that patients can develop are flu-like symptoms, such as malaise, fever, nausea. They can have myalgias as well. So those are, have been reported. You might have to stop temporarily the treatment. You do need to exercise caution for patients with pre-existing autoimmune diseases, just because there have been some case reports of exacerbation of autoimmune conditions, as well as of inflammatory conditions of the skin. Also, patients who are using immunosuppressive drugs, whether methotrexate, cyclosporin, tacrolimus, and other immunosuppressive drugs, you do need to exercise caution for these patients. Currently, it's not recommended. For patients, so just in the management for patients who have really intense local skin reaction, it has been reported that 1.2% will have to discontinue the treatment if it's at 3 times per week. So like I was telling you, I usually start slow, especially in my older patients. I will start, first week it's once per week. If it goes well, second week and third week, I'll go up to twice per week. And if it's well, I'll go up to 3 times per week. And sometimes from 2 to 3 times per week, that's where we actually see the reaction. So when, when we discontinue it and we start it again, it's once per week and we go up to twice per week, but we never go back to 3 times. There was a Cochrane review that looked at imiquimod compared to placebo. So not, what we see is that overall response was in favor of imiquimod, as well as complete response when compared to placebo. So we're not surprised with this. There was only one study that looked at, progression to vulvar cancer at 12 months. So, we didn't have enough patients to have a full picture. It favors imiquimod, but this was not statistically significant. And lastly, they also looked at HPV DNA persistence, and patients in the imiquimod group had a reduced risk of having HPV DNA persistence during follow-up. If we look at cidofovir, so this is another off-label description. So I've never used it. It's an antiviral that is mostly used for CMV retinitis in patients with AIDS. It can be also used for patients with herpes virus infections that are not responding to other types of treatments. It's a 1% gel. It needs to be applied 3 times per week as well. Some studies have used it until 24 weeks of treatment. And I couldn't just see, the whole dosing, but in one study, they were saying that a 10-gram tube should last 6 weeks. There's a phase 2 randomized controlled trial, RT3 VIN, that, the first report I think was published in 2016, and then there was some follow-up data in 2018. That, the goal of this study was to compare topical treatment with either cidofovir or imiquimod for VIN3, so high-grade lesions, and patients were randomized to either, to one of the two arms, to be applied 3 times per week for 24 weeks. So in comparing both groups, on long-term follow-up, there were no differences in grade 2 and plus in grade 3 and higher adverse events, although they seem to be a little bit higher in cidofovir group, but this was not statistically significant, and recurrences were a bit more common in the imiquimod group. When they did a multivariate analysis on, to assess factors influencing the time to new VIN, they found that the imiquimod group had shorter time to new VIN lesion with a hazard ratio of 3.5. There was a tendency for multifocal disease and recurrent disease prior to treatment to be associated with shorter time, but these two were not statistically significant. And finally, there's another study that took the same patients from their RT3 VIN study, and they tried to assess, what was the difference, what would modulate the response, and this would possibly be linked to E2 methylation. Another medical treatment is photodynamic therapy. This is usually done by a dermatologist. It requires the application of a topical photosensitizer, either 5-ALA, and I'm sorry, I need to read this. It's 5-aminolevulinic acid, and MAL is methyl ester methyl aminolevulonate. And then the skin will be illuminated with a light of appropriate wavelength. Complete response varies across studies. It goes from 20 to 67%. However, recurrences are common. Up to 90% of patients will recur within 2 years. There's also not a lot of good data on the subject. Studies are very heterogeneous. And this is a painful technique. About 40% of patients will require anesthesia for treatment. And finally, another downside of this treatment is that it does require specialized equipment and training, which makes it not available in every center. There's a little bit of hope, though. There are a few ongoing trials. Some of them have been running for quite some time, and I've been trying to get, find results, but there's nothing. And even on the clinical trials registry, a lot of them have not been updated since 2014. So there's one trial that hopefully will have the results is comparing imicumod and surgery for primary treatment of VIN. There's another one with a synthetic HPV vaccine with E6 and E7 peptides plus imicumod versus that HPV vaccine alone. There's a third trial looking at imicumod and HPV vaccine versus imicumod alone. A fourth trial looking at photodynamic therapy versus imicumod. And finally, a fifth trial that is looking at a new molecule against placebo. Patients with usual VIN are at high risk for recurrence. It's stated to be about 30%. Risk factors for recurrence are active smoking, positive surgical margins, multifocal disease, immunosuppression, as well as large tumor size. The risk of recurrence correlates with pre-treatment HPV type. So although it's most commonly HPV 16, it has been shown that HPV 31 and 33 are associated with more rapid growth of lesions than HPV 16, and they are associated with higher risk of recurrence. Also, another factor to consider is that patients who had surgical excision with laser ablation of the surgical margins appear to have a decreased risk of recurrence when compared to excision alone or other medical treatments. When we talk about usual VIN, we do, we talk about HPV, we do need to consider vaccination. So I will not be teaching you anything, but the available vaccines are virus-like particle, VLP, from the L1 component of the virus. We do have two vaccines available, the quadrivalent and the nonavalent vaccine. I've wrote down again the types of HPV that are included in both. And so when we look at efficacy to prevent VIN2+, so high-grade lesions, for women aged 16 to 26, when combining protocol 007, future 1, future 2, we have different numbers. So in the general population, so patients who had at least one dose of vaccination, irrespective of their HPV status, it was 76% effective to prevent VIN2+ lesions in women aged 16 to 26. For patients who were HPV naive and who received the full dose, it was 100%. However, we don't have at least as much data for women in the age group 24 to 45. The efficacy in that age group for general population, so at least one dose, and we don't know the HPV status, was only 22%. And then it was 63% in the group of women who had at least one dose, but whom we knew they were HPV negative. We don't have the efficacy for patients who did the full 3 doses within a year and who were HPV negative in that age group because there were no cases of VIN2+ in either group. There's another study that was published by Warner and colleagues in 2017 in the Lancet, which was a double-blind randomized controlled trial comparing quadrivalent and nonavalent HPV. They randomized 14,000 patients. And so what it showed for vulvar and vaginal disease, it was put together, is that we have it here. For disease related to HPV 6, 11, 16, or 18, there was a 16% risk reduction, but it went from -201 to 75. But for the group of disease related to HPV 31, 33, 45, 52, and 58, there was a 94% risk reduction. And this is explained because, they were comparing the 2 vaccines, and these types of HPV were not included in the quadrivalent. However, for VIN2+ and vulvar cancer, there were no cases in either group, so we could not conclude on the subject. Looking at the subject, there was a systematic review published by Brian et al. Last year, and The objective of this study was to look at the role of HPV vaccine in secondary prevention and treatment of vulvar and vaginal intraepithelial neoplasia. They included 7 studies. There were no RCT. And so this means a total of 129 patients, which is not a lot for a systematic review. This systematic review looked at 4 outcomes. The first one was lesion regression. So this encompassed partial response and complete response, and this ranged from 0 to 83%, depending on the studies. When looking at symptom relief, between 0 and 68% of patients became symptom-free. HPV clearance was seen in 8 to 74% of patients, and histological regression, which means downgrading from high-grade lesion to low-grade lesion, was seen in 0 to 63% of patients. Interestingly, none of these studies that were included used commercially available vaccines. So there's another trial that is recruiting, which is the VIVA trial. It's a double-blind, placebo-controlled, randomized controlled trial. The objective is to test whether the licensed prophylactic nonavalent HPV vaccine can reduce the risk of HSIL recurrence by 50% in previously unvaccinated individuals recently treated for anal or vulvar high-grade lesion. The target is 345 patients, and the study has an estimated completion date of December 21st, 2021. So this will be interesting to look at the results when it comes out. For follow-up, so there's not a lot of guidelines on the subject. There's no study looking at, how they should be followed. When you look at the only guidelines I could find, which were from the ACOG in 2016 and that were updated in 2019, the recommendation was that if patients had complete response to treatment and no new lesion, then you could follow up at 6 and 12 months after the initial treatment. If everything was normal at that point, they could be followed every 12 months afterwards. This follow-up would include visual inspection plus minus biopsy if there's any suspicious lesion. And you do need to remember to assess the whole lower genital tract. An important aspect is you do need to counsel about smoking cessation because we do know that it is associated with persistence of HPV infection. You do need to counsel patients on warning signs of recurrence or of cancer, so they don't wait for their 1-year appointment, but they call you sooner if there's a new bump that they can feel. You can consider HPV vaccination, although we don't have strong data on the efficacy to treat, but these patients might be at risk of acquiring a new infection. So this needs to be discussed. And this you will not find in papers, but if you have recurrent disease with no risk factor, you can consider an assessment for immune deficiency. I've had a few patients, where it was weird. They kept, having recurrent disease. They were non-smokers, regular partner for 40 years. And so I sent them for an immune check assessment. And, I think most of them have been found with some kind of immune deficiency. So it's interesting. If we go to differentiated VIN, so this is is not as common as usual VIN, and really there is not as much literature on the subject, probably because it is not as well recognized and it has been underdiagnosed. Right now, it represents about 10 to 20% of VIN cases, although the true incidence might be higher. It happens in older women compared to the usual VIN, so in the 6th to the 8th decades. It's an HPV-independent disease, and risk factors, it's mostly lichen sclerosis, and lichen planus has been traditionally associated with it, although some authors are challenging this concept right now. If we look at pathology, so the diagnostic criteria will require some basal atypia, P16 will be negative, as you can see here. And P53, you can either have basal overexpression. So here you can see all along the basal layer. You can have wild type, I don't have a picture, or you can have aberrant negative. So you really have nothing that lights up for P53. This is an algorithm showing the morphologic subsets of differentiated VIN. It's more for your information. I will not go into the details. I'm not a pathologist, so I'm clearly not an expert on this, but it can be useful for reference. When we look at clinical presentation, so most patients will be asymptomatic. Some patients will be asymptomatic, about 10%, but most patients will have symptoms, either pruritus, dysuria, dyspareunia. Patients can have some bleeding, fissures, pain, burning sensation. And you can have different, types of lesions. Often we'll see the white or the gray white or lesions, but it can be pink and red as well. The DVIN most often involves pericleral structures as well as the labia minora, less often the perineum or the perianal region. However, as you all know, lichen sclerosis, which is probably the precursor to DVIN, tends to develop in a figure of 8 in this region. So DVIN can develop anywhere on that in these anatomical limits. So if we look at the pictures, here it's very subtle. So you have a white glazed lesion on top of the clitoris that if you look quickly, you might not perceive. And then on the second picture, we have more of a red type of DVIN with both labia minora involved, as well as the interlabial fold on the right side. Otherwise, you see the changes that we see with the lichen sclerosis. Also, traditionally, DVIN has been described as a unifocal disease, but up to 20 to 50% of patients will have, at least 2 or more non-contiguous sites. So, we can't say, oh, it's multifocal, then it's usual VIN, it's HPV dependent. It's not that simple. Patients with DVIN have a high risk of cancer. Most studies state around 50%, but there has been some reports of 85 and 90%, which is quite significant, a risk of progression to cancer. And the median time to progression in the literature goes from 23 to 44 months, but is more often cited to be around 2 years. So, almost half the time for usual VIN. So how do we manage DVIN? So, the first step, and this is really important, and I think all authors concord on that, is that you do need to have a biopsy. So for usual VIN patients, some guidelines say, you don't need to necessarily to have a biopsy, but if you suspect DVIN, you do need to have a biopsy. And the ISSVD in their recent guidelines, they describe well how the specimen needs to be obtained. So it needs to be a 4 millimeter width, 5 millimeter depth for hair-bearing skin, or 3 millimeter depth for non-hair-bearing skin. Each individual lesion should be biopsied at the most suspicious part of the lesion. And if there's an ulcer or a fissure, you should make sure to take some intact epithelium. And you can also do some mapping biopsies to aid with resection margins at the time of surgery. How do you manage it? You need to do surgery. So excision is really the gold standard for DVIN lesions. I have put in a small case laser. So this is not standard, but in some patients who already have had excisions, who have some recurrent disease, older patients, you might consider laser. I have I think 88 years old patient who had stage 1A vulvar cancer. She had a big resection, and she has some recurrent DVIN around the urethra. She does not want to have another resection, and she would probably have some continence problems afterwards. She's very active. So she's had 2 lasers. So far, we haven't had any cancer develop again. And so although most authors recommend surgical excision, there's a recent French publication which is advocating for the use of potent topical steroids as primary treatment of DVIN, although it's the only publication that I could find on the subject. For follow-up, so there's not a lot of data, but it needs to be long-term. The question is who should be responsible for follow-up? Like for usual VIN, it needs to be someone who feels comfortable examining the vulva, who's able to do a biopsy or refer quickly for a biopsy to be done. As previously stated, there's a high risk of recurrence. So, they need to be seen probably every 6 months, at least in the beginning. Is there a role for topical steroids? There's no data looking specifically at that. It does appeal that, if it develops in the context of lichen sclerosis, then it might prevent progression to DVIN. So why not? I do have quite a few patients that are still on clobetasol. And you can't hesitate to biopsy if there's anything that looks out of the ordinary, any change, you do need to take a biopsy. And then quickly, other precancerous lesions. So these are a newer class of precancerous lesions. They are HPV independent. They are characterized by aberrant maturation with minimal nuclear atypia. And it's kind of an umbrella term for different pathologic entities. There's the devil, which is the differentiated exophatic verruciform intraepithelial lesion. There's the VAD, which is the vulvar acanthosis with altered differentiation, atypical epithelial acanthosis, and lichen sclerosis with acanthosis. And so these lesions are being studied right now. I think there's about 3 publications on the devil and probably the same amount on VAD. They are thought to be precursors to verrucous carcinoma, but further studies need to be performed. The diagnostic criteria, according to the ISSVD, require aberrant maturation or premature maturation from the basal layer, acanthosis, and minimal basal nuclear atypia. P16 will usually be negative, and P53 usually wild type or overexpressed, but the staining for P53 needs to be limited to the basal layer. Patients, like for other precancerous lesions, can be asymptomatic. They can have pruritus, they can have a burning sensation or pain. And on examination, they will have well-demarcated white papular plaque, which you can see here, and often will have an irregular or verruciform surface. It will be most commonly as well as on periclitoral structures or labia minora, and it will happen in a field of chronic dermatitis. So how do you manage these lesions? Once more, there's not a lot of data on the subject. It has been advocated to try potent topical steroids first, since it develops in the field of dermatitis. So you could try clobetasol. If it doesn't work, then you should proceed with excision. There's no data on follow-up, but probably long-term, because there's this field effect of dermatitis again. So in conclusion, we have 3 separate entities of premalignant vulvar lesions, each with their own characteristics and their own management. It's important to biopsy one to rule out invasive cancer, and also to have an accurate diagnosis so that the appropriate treatment can be administered. Medical treatment is an option for usual VIN, whereas DVIN should be managed surgically. And there's a lot of potential for future research projects, since there are so many clinical questions still unanswered. So for those of you who are interested, go ahead.